to our final education session. For the benefit of those who didn't attend yesterday, I'll just repeat a few important things. Please sign in on the sheet outside. And then this is the most important thing. If you haven't already texted your phone number on the screen, you won't be able to complete an evaluation, and if you don't do that, you won't get your CNA. So if you haven't figured that out yet, you can talk with Jennifer just outside. Please silence your cell phones. And then now I'll introduce our first speaker, Dr. Ashley Evans from Digestive Health. She joined them in 2013. She's originally from Portland, Oregon. She received her undergraduate education at Santa Clara University in California. She graduated from Oregon Health and Science University School of Medicine and then completed both internal medicine and gastroenterology fellowship in Seattle at the University of Washington. She has a special interest in Crohn's disease and ulcerative colitis and received additional training in inflammatory bowel disease at the University of Chicago. Dr. Evans is married and has 3 children. She enjoys running, hiking, kayaking, and traveling. And in her first talk of the day, Dr. Evans will speak.
We switched them.
To gut health?
No, we're going to do IBD first.
We're going to do IBD first. That's right. That's amazing. Okay. All right. Thanks, Dr.
Okay.
Evans.
All right. Can everybody hear me okay? Okay. So thank you so much for having me. I spoke actually about 10 years ago at the ACMS Winter Clinics, and so I'm really happy to be back. It's very early in the morning, so thank you all for showing up at 7 o'clock. And I know it's been a long weekend, and so I especially appreciate you sticking around till the end to hear my talk, Dr. Wheaton's talk, and then I have one final talk at the end about gut health. All right, so it sounds like you've seen these screens a couple times. Oh, it's because of this? Because of the Zoom?
This testing on good. Right.
Okay, great. Okay, so we're going to be talking today about inflammatory bowel disease for primary care physicians. And the first question is, what is IBD? So inflammatory bowel disease, we call it IBD for short. And there really are 2 flavors. So chocolate vanilla, we call it Crohn's disease, and ulcerative colitis. I'm sure everyone in this room has heard of both of these, but they're sort of the same, but very different. So let's talk about Crohn's disease first. Crohn's disease is a transmural inflammation of the GI tract that's characterized by skip lesions. So normal bowel and then inflamed bowel, normal bowel, inflamed bowel. And the transmural part of this is really important. So sort of keep that in mind. Transmural means the inflammation goes from the mucosa all the way through the bowel wall to the serosa. So that's one of the hallmark features of Crohn's disease. And that transmural inflammation means that the bowel can become scarred and strictured. We also get things like fistulas, abscesses. These are all hallmarks of the disease. And you can get bowel obstructions from these strictures or scar tissue building up. The inflammation typically is located at the end of the ileum or the very beginning of the colon. So that's where we usually see this disease. But keep in mind that Crohn's disease can actually involve any part of the GI tract from the mouth through the small intestine, the colon, and to the anal canal. So patients can present with many symptoms based on where their inflammation is located. In contrast, ulcerative colitis only involves the colon, and it's not transmural. So the inflammation is limited to the mucosa. So we don't get that destructive nature of the disease where you can get scarring and strictures or sinuses or fistulas, typically not abscesses either. This disease starts in the rectum. It almost always involves the rectum, and so patients present with different symptoms. But if it doesn't involve the rectum, then we think maybe it's not ulcerative colitis. If it's not involving the rectum and it only involves the colon on the right side, then that's atypical for colitis, ulcerative colitis, and would be more suspicious for Crohn's colitis. So these are the things that you're going to see when somebody with inflammatory bowel disease walks into your clinic. This is a picture of Crohn's disease. So cardinal symptoms of Crohn's disease are abdominal pain, diarrhea, does not necessarily need to be bloody diarrhea, because if it's not involving the rectum, patients might not see blood. Fatigue and weight loss are also pretty classic symptoms of Crohn's. The colonoscopy, like this patient, might show deep serpiginous ulcers in a patchy distribution through the colon and the small intestine. And it can involve, like I said before, any portion of the GI tract from the oral cavity. So you might just present with aphthous ulcers in the mouth, or to the perianal area, which would present with fistula and abscesses. So this is actually a patient of mine with terrible Crohn's colitis. And this is a picture of her rectum. So you can actually see that there are patchy areas. So there's areas that look more normal. Then there's these deep serpiginous ulcers. There's, let's see if my pointer works. Yeah, so right here, this is actually a hole, right? So she has a fistula in the rectum, and she presented with terrible diarrhea and perianal fistula. She's actually doing really well on Remicade, completely in remission. So in contrast, this is a picture of a patient of mine who has ulcerative colitis. So patients with UC present with bloody diarrhea, almost always. And the bowel movements might be more frequent, smaller in volume, and that's because the rectum is always involved. And depending on how much of the colon is involved, that will kind of determine how severe the symptoms are. Associated symptoms are going to be colicky abdominal pain, urgency, tenesmus, and incontinence. So the way I describe this to patients who are saying, I have to go to the bathroom every 15 minutes, I have the sensation of urgency, I sit down and nothing happens. So the rectum is designed to be stretchy. And when the rectum is not stretchy, it's because it's inflamed. So this is compliance, right? So the reason we have a compliant rectum is because when the stool hits the rectum and it's not convenient to have a bowel movement, it sort of just stretches until it's convenient, and then you can use the restroom on your own time. But if you have inflammation, you lose that compliance. And so stool hits the rectum, patients have the sensation they have to go to the bathroom right now. They have that urgency, and they have to get to the restroom quickly. It's really important that we recognize that inflammatory bowel disease is not irritable bowel syndrome. So about 12 years ago, I gave a talk to a primary care audience, and I finished the talk on inflammatory bowel disease, and somebody in the audience said, so is this different or the same than irritable bowel? And I was like, oh gosh. So I'm sure everyone in this room knows that irritable bowel is not inflammatory bowel disease. And this is a picture of somebody with irritable bowel, which means it's totally healthy, it looks absolutely normal, but the symptoms can be overlapping and sometimes difficult to distinguish. So symptoms of abdominal pain and diarrhea can totally be irritable bowel syndrome. But when we look with the colonoscope, when we do labs, when we do imaging, when we take biopsies, patients with irritable bowel syndrome have completely normal results. And they don't have or shouldn't have red flag symptoms. So weight loss, rectal bleeding, nocturnal bowel movements. That's a really good question to ask in your clinic. So patients are having 10 bowel movements a day. That's not normal. But then you say, do you ever have bowel movements in the middle of the night? That's really not normal. So that is a red flag symptom. Do they have any extraintestinal manifestations of IBD? That would raise our suspicion this might not be irritable bowel syndrome. So again, remember, IBS looks very normal. Inflammatory bowel disease, there's obvious inflammation both endoscopically and histologically. Okay, so really important question. What causes inflammatory bowel disease? And I'm going to tell you, we haven't actually figured this out yet, but there's a lot of theories, and we've gotten a lot of information to help us kind of figure out who's at risk, what causes this disease, and what can be done about it. So in 1913, T.K. Dalzell described Crohn's disease for the first time. It wasn't until 1936 that actually Burl Chron wrote in JAMA about Crohn's, so he got to coin the disease. Instead of calling it Dalzell disease, we call it Crohn's. So in 1913, Dalzell said, I can only regret that the etiology of the condition remains in obscurity, but I trust that ere long further consideration will clear up the difficulty. So where have we gotten in the last 100 plus years trying to figure out the etiology of Crohn's? In 2014, in Nature, Core wrote, IBD is thought to result from an inappropriate and continuing inflammatory response to commensal microbes in a genetically susceptible host. So what does this mean? It means it really takes the perfect storm in order for someone to get Crohn's. So you have to have the luminal microbial antigens and adjuvants, so the bad bacteria in the gut. You have to have an inappropriate immune response to that bad bacteria and environmental triggers to kind of kick it all off. And you have to be genetically susceptible. So all these things have to come together in order for a patient to get Crohn's disease or ulcerative colitis. The bad news is that the incidence rates are rising pretty dramatically. So this was published in 2004 in Gastro, and it was looking at the incidence in multiple communities, so one in Olmsted County, Rochester, New York, as well as other industrialized nations in the world, looking at incidence of Crohn's, as well as incidence of colitis. And unfortunately, incidence rates are rising pretty dramatically and steadily over time. Same thing for ulcerative colitis. So who gets inflammatory bowel disease? This was published in 2017. It's a great study published in Gastro and Hepatology, 195 countries. This was sponsored by the Gates Foundation. So they did a really extensive overview of who's getting inflammatory bowel disease throughout the world. So we used to think of Crohn's and colitis as a bimodal distribution. So there's a peak in the 20s and then there's another peak in the 50s. But this data actually shows us that it looks to be more peaking in the 50s primarily. So increases by age over time and then decreases after the age of 50. And we can also see that females are more predominantly affected than males are. We don't know why. But it seems to be consistent over time and throughout all age groups. And the geography is really interesting. So this is one of the things that researchers are really trying to dive into. Red is bad, blue is good. So red means increased incidence. So you can see that it's primarily Northern Hemisphere, primarily industrialized countries. And we don't know why exactly. There's a lot of theories about this, and I'm going to get into this a little bit more in my second talk about gut health, so stick around for that one. But basically, Southern Hemisphere seems to be protected, and it seems to be better if you don't live in an industrialized country. Okay, so genetics. Genetics was one of the pieces of the perfect storm. You have to have all of these things in order to get inflammatory bowel disease. So how important is genetics? Well, it really only accounts for about 20 to 25% of the risk of developing inflammatory bowel disease. And we know this from twin studies. So monozygotic twins, if you look at their risk for developing inflammatory bowel disease, only about 10 to 15% of monozygotic twins will both develop ulcerative colitis and about 30 to 35% of Crohn's disease. So actually suggesting that the non-genetic factors play an even more important role than genetics alone. And the one caveat to that is a gene that's been found on chromosome 16 called NOD2. So patients who have 2 copies of NOD2 actually have a 17 times increased risk for Crohn's disease. These kids get Crohn's really early in life, so before age 10, still have a risk if they're heterozygous as well. And there are environmental influences that increase your risk for inflammatory bowel disease. Lots of work going on in this area. But a few of the environmental influences that we know for sure trigger or increase risk for Crohn's disease and ulcerative colitis. So smoking, and actually this one's a little bit interesting. Smoking has a protective effect for ulcerative colitis. So patients who quit smoking, that sometimes can trigger their first flare. Strange. And then for Crohn's disease, it actually confers worse diagnosis, increased risk. NSAIDs can cause bowel inflammation and can increase the risk for inflammatory bowel disease. Having an appendectomy, again, one of those sort of not controversial, but contradictory risk factors. An appendectomy can be protective for ulcerative colitis, but actually increases the risk for Crohn's disease. And the microbiome and the diet, we know that these are involved. We know that they can increase or decrease risk, really trying to understand how these things are involved. And again, in my second talk, I'm going to get into that in a little bit more detail. Probable environmental influences that increase the risk for inflammatory bowel disease: antibiotic use, low vitamin D levels, childhood infections, and speculative. So we think these might be involved, but we're not entirely sure. Hygiene. So there's this idea called the hygiene hypothesis, which is that people in cleaner countries have an increased risk. So industrialized nations, maybe because our world is so clean, that increases our risk because the immune system is sort of not doing what it's supposed to do in a world that isn't exposing us to normal pathogens, normal bacteria, fungi, viruses, because they've been cleaned. Exercise, potentially, oral contraceptives, stress, and medications. There's the Accutane theory. Perhaps Accutane increases the risk for inflammatory bowel disease and other medications. These are all speculative, however. And the gut microbiome, like we're going to talk about this more later, but we definitely know that the gut microbiome in normal people is different than that in patients who have inflammatory bowel disease. So this is an example of a normal microbiome. So someone who does not have inflammatory bowel disease, composed primarily of Bacteroides and Firmicutes. And then when we look at the microbiome for patients who have inflammatory bowel disease, you have decreased levels of that normal healthy Bacteroides and Firmicutes, and you have increased levels of pathogenic bacteria. I want to talk a little bit about extraintestinal manifestations of IBD, because this is going to be something that you see walking into your clinic probably more frequently than I will. So these are really important things to recognize in a patient either who has been diagnosed with IBD or who walks in with IBD type symptoms and you see extraintestinal manifestations. This should obviously raise your suspicion of IBD. So inflammatory bowel disease can be associated with inflammation outside of the GI tract. And we think of these in the categories of mucocutaneous inflammation, ocular inflammation, musculoskeletal, hepatobiliary, renal, and vasculature. And who gets these extraintestinal manifestations? It's actually pretty common. So about 40% of patients with IBD can develop extraintestinal manifestations. It's more common in patients with Crohn's, and it seems to be increased risk for patients who have colonic involvement. And about 25% of patients will actually have more than one extraintestinal manifestation. So let's start with mucocutaneous, excuse me. So these are aphthous ulcers, erythema nodosum, and pyoderma gangrenosum. Aphthous stomatitis is really common. It's more common in Crohn's disease, but it can be seen in ulcerative colitis as well. It occurs in about 10% of children with IBD, 3 times more common than in Crohn's disease. And treatment includes treating the underlying disease, so getting the bowel inflammation under control helps with the stomatitis, using any viscous topical oral solutions for pain relief, and correction of nutritional deficiencies. Erythema nodosum, this is a pretty common extraintestinal manifestation, about 10 to 20% of patients with IBD. And classically, the board's question is, on the extensor surfaces of the shins. These are hot, red, tender nodules, and the activity correlates with the inflammation in the bowel. So when the bowel disease is flaring, this is when patients tend to develop erythema nodosum. This can occur as well with peripheral arthritis. So something to look out for and recognize. Pyoderma gangrenosum is less common, about 1 to 10% of patients. This can look really, really awful. I don't know if anybody's ever seen pyoderma, but it usually is identified as an infection by the first person who sees it. It's seen in the emergency room. Somebody thinks that this is cellulitis. And because the wound can become ulcerated, it's erythematous, it has this sort of pustule look to it. And so typically patients will get treated with antibiotics. It doesn't get any better with antibiotics. What they need is treatment of their IBD and high-dose steroids. Ocular manifestations occur in 1 to 4% of patients with inflammatory bowel disease. The most common ocular manifestations are going to be episcleritis and scleritis. Uveitis can also be seen in IBD. And we also get treatment-related complications as an ocular manifestation. So patients who are using steroids for their inflammation can develop subcapsular cataracts. So it's really important that patients who are on long-term steroids, which of course we're all trying to avoid, have an annual eye exam. And this is one of those things, if your patients have ocular manifestations, it's really helpful if they get established with an ophthalmologist early, because we all know how hard it is to get in to see an ophthalmologist sort of last minute. So if they're an established patient and they develop an ocular manifestation, they can get in more quickly. So this is a picture of episcleritis. So what we see is injection of the sclera and the conjunctiva. It does not affect visual acuity. It's not so much an emergency. It does need to be treated typically with steroid drops or just inflammation control in the bowel. So this gets better when we get the bowel inflammation under control. Remember, scleritis and episcleritis do not affect vision, in contrast to uveitis, which actually does affect vision, leads to blurry vision and photophobia. So this is a lot more important to recognize because it's an emergency. This manifests with headache, deep eye pain, tearing, often presents insidiously, bilateral involvement, and it needs prompt evaluation by an ophthalmologist so that patients don't become blind. Let's move on to musculoskeletal extraintestinal manifestations. This is the most common location for extraintestinal manifestations. This occurs in about 40% of patients, presents with arthritis. The arthritis can be peripheral or it can be axial. And we also are always looking out for metabolic bone disease. Osteoporosis and osteopenia are incredibly common in this patient population, so something to look out for. Peripheral arthralgia, waxing and waning joint pain and stiffness in association with a flare of the intestinal disease. So again, the bowel flares and the peripheral arthralgia gets worse. This occurs in 10 to 20% of IBD patients. It looks like swollen, red hot joints. It can be asymmetrical, migratory. It's non-destructive, and this is not rheumatoid arthritis. So this is seronegative arthritis. And the risk of arthropathy increases with the extent of colonic involvement. Axial arthropathy is a different beast. So this is occurring in the midline along the spine. This occurs in 7 to 25% of patients with IBD. It does not parallel the bowel activity or the bowel inflammation. And it usually manifests as insidious low back pain and morning stiffness that's improved by exercise. So we're all accustomed to asking that question, joint pain, does it hurt worse in the morning or does it hurt worse when you've been working or standing on your feet all day? So this axial arthropathy is going to be morning stiffness, morning pain. It gets better when they move around. Sacroiliitis, so you can see there's fusion of the sacroiliac joint. This occurs in 10 to 15% of patients with IBD, males more than females, dull back or hip pain, worse in the morning, and these patients are HLA-B27 negative. And then as opposed to ankylosing spondylitis, so this is pretty rare. It occurs in 1 to 2% of patients with IBD. I have a handful of patients with ankylosing spondylitis. It's really sad. Once they get spine fusion, I mean, they literally cannot flex their neck. They can't turn their head. These patients are HLA-B27 positive, and their symptoms can appear long before or after the onset of intestinal symptoms, so they don't go hand in hand with the bowel inflammation. So this is also called bamboo spine, ankylosing spondylitis. Metabolic bone disease, super important for us all to recognize because it's so common in these IBD patients. Osteopenia and osteoporosis. Glucocorticoid use is the main risk factor for colitis patients. So for ulcerative colitis patients, they've been on and off steroids for years and years. But in Crohn's disease, it's for many reasons. So not only steroid use, but Crohn's disease patients have malabsorption of calcium and vitamin D. There are effects of pro-inflammatory cytokines on the osteoclast, and they have low body mass index. And so we're always telling our patients above 65, weight-bearing activities reduces your risk of osteopenia and osteoporosis. Well, these patients are chronically underweight, and so they have increased risk for metabolic bone disease. Okay, hepatobiliary complications are primary sclerosing cholangitis, drug-induced hepatotoxicity, and gallstones. Increased risk for all of these things in patients with inflammatory bowel disease. Hopefully you've all heard of primary sclerosing cholangitis. So this is an inflammatory condition of the bile ducts in the liver. And what happens is you get this fibrosis of the bile ducts, and on MRCP or sometimes CT scan, you'll see this or beaded appearance of the bile ducts. So in between the scarred down areas, it's dilated, so it's dilated and strictured. And this occurs in about 4% of patients with Crohn's disease and 8% of patients with UC. And one really important thing to remember is that patients with inflammatory bowel disease and primary sclerosing cholangitis are at increased risk for both colon cancer and cholangiocarcinoma. So they actually have to be getting annual colonoscopies and annual MRIs to look for these conditions. So if you get a patient who comes into your clinic, they haven't had a colonoscopy in a couple of years and they have coexisting PSC, really important to get that patient back in for their annual colonoscopy. Drug-induced hepatotoxicity. This happens really commonly, just, like any medication can cause a drug-induced liver injury. We do see this commonly with sulfasalazine, azathioprine, methotrexate, rarely with infliximab or Remicade, but just something to keep an eye on. In my patient panel, patients are getting labs at the minimum every 6 months, and depending on what medications they're on, every 3 months. And sometimes it feels like overkill, but obviously you don't want the patient to be on a medication that's causing hepatotoxicity or bone marrow involvement. So we do check labs relatively frequently in the IBD world. And then gallstones. Gallstones are more common in the IBD patient population than in the general population. And we see this about 13 to 34% of the time in patients who've had ileitis or an ileal resection. And the reason is because bile salts are typically reabsorbed into the hepatobiliary circulation in the terminal ileum. So if you've had a resection or you have inflammation of the terminal ileum, then you can't reabsorb those bile salts. So then what's in the gallbladder, in the biliary tree, then becomes supersaturated, becomes a nidus for crystal formation, and then you get stones. So be on the lookout for gallstones in your patients with inflammatory bowel disease. Renal extraintestinal manifestations. The one that I think about most commonly is actually kidney stones, so nephrolithiasis. This happens in about 2 to 6% of patients with IBD, more frequently in Crohn's disease and ulcerative colitis, and the reason is just scientific. So in Crohn's disease patients, the free fatty acids in the bowel are not absorbed as effectively. And so instead of being absorbed, those free fatty acids pass into the colon and they bind calcium. And instead of binding oxalate, which is what calcium is typically supposed to do in the bowel, they bind the free fatty acids. So then you have increased levels of oxalate. Oxalate goes to the kidney. Oxalate causes oxalate stones. So this is due to malabsorption in Crohn's disease. You can also get uric acid stones because of volume depletion and being in a hypermetabolic state. And vascular. If you take one thing away from this talk, I would love it to be that patients with IBD are at increased risk for vascular complications and they're hypercoagulable. So this is really important in the inpatient setting. Patients who come into the emergency room, they're in an IBD flare and they don't get their sub-Q heparin or their Lovenox because they're having bleeding. And these patients are at a really increased risk for clotting. So DVTs, PEs, myocardial infarction, stroke. So this is because when patients are in a flare, right, they have increased level of platelets, which is an acute phase reactant. So they have thrombocytosis, they have increased levels of clotting factors, also acute phase reactants, and they have low levels of antithrombotic factors because of active bowel inflammation. They're actually spilling antithrombotic factors through their gut. So really important. They don't need to be, as an outpatient, anticoagulated, but keep in mind that they are at increased risk. And so that's another reason why it's important to get their inflammation under control and don't hold their blood thinner just because they're bleeding. We can always treat bleeding. We can't always treat a DVT or a stroke. Okay, so the treatment of inflammatory bowel disease, I really don't want to get into the weeds with this too much because hopefully these patients are being sent to me and we're doing the treatment, but I do want you to be familiar with the medications. So this is what I draw for patients, all patients who come into my clinic. We're talking about changing medications, starting medications, new diagnosis. And I just find that this is an easy way to understand the medications that we use for inflammatory bowel disease. So I start at the top and I say steroids. Steroids are a Band-Aid. So steroids are covering up your symptoms. They are not treating the underlying bowel disease. And we can really get into trouble if we use steroids too often or too frequently, or at too high of doses. So steroids help in an emergency. They might keep you out of the hospital. They might keep you from having surgery. They are a good bridge to maintenance therapy, but they are not for long-term therapy. And this is because the side effects of steroids increase over time. So things like diabetes, osteoporosis, glaucoma, we want to avoid these complications if we can. And the other reason that we don't like to use steroids is because it means we're not actually treating the disease, right? We're just covering things up. So that's why I tell them this is basically a Band-Aid therapy. And then what I try to do is match the degree of inflammation to the strength of the medication. So for patients who have mild disease, we'll use mild therapy. For patients who have severe disease, we're going to be talking about biologic therapy. And the one caveat to this is I almost never use aminosalicylates or mild therapy for Crohn's disease. And the reason is because Crohn's disease is transmural, right? So the inflammation is not just at the mucosal level, it's going all the way through the bowel layers. So if we use a medication that is topical, which is what aminosalicylates are, mesalazine and sulfasalazine, We're only treating the surface of the inflammation. Great if that's where your inflammation is, if you've got ulcerative colitis and the surface is the only thing that's involved. Bad if you have Crohn's disease and the inflammation is going transmural through all the layers of the bowel. So very rarely for patients with mild Crohn's disease, I might use an aminosalicylate, but typically we're moving on to more moderate or biologic medications. So the aminosalicylates, there's about 10 of them, and we use them frequently. They release in slightly different areas of the bowel, so depending on if you have left-sided inflammation or rectal inflammation, that might change which medicine that we use. These medications are really safe. The active ingredient in aprezo, delzacol, acecol, lialda, pentasa, balsalazide is mesalamine, and then sulfasalazine is a slightly different medication, still a topical therapy. It's used in the rheumatology world for inflammatory arthritis, and it becomes activated in the colon. And so it doesn't work in patients who don't have a colon, and it doesn't work for small bowel inflammation. So moderate disease, we're moving on to our stronger medications, and this next category is called the immune modulators. So we're talking about Imuran, also called azathioprine, 6-mercaptopurine, which I describe to patients as like a sister medication to Imuran. So 6-mercaptopurine is basically just metabolized Imuran, and then methotrexate, also used frequently in the rheumatology world. Methotrexate scares patients because they think of it as a chemotherapy medication. So at high doses, IV, we're using methotrexate for leukemia, lymphoma. At low doses, orally or subcutaneously, this is a really effective treatment for inflammatory bowel disease, inflammatory arthritis. It's taken once a week. We have to make sure patients are on folic acid. For severe inflammation, we're moving on to the biologics. So patients are scared of biologics because they feel like it's this really strong medication that's going into their system, and it's going to make them immunosuppressed. I have a lot of thoughts about this. I'm not going to get too deep into whether these patients are immunosuppressed or not, but here's what I tell patients, and you can feel free to use this as well in your clinic. I don't view you as immunosuppressed. The problem is that your immune system is abnormal, right? So your immune system is not doing what it's supposed to do. Your immune system is attacking your bowel. And what we're doing with these medications is we're trying to make your immune system act more normally. So we are taking your abnormal immune system, we're using a biologic medication or an immune modulator to change the focus of what your immune system is doing and to basically tell it to stop attacking the bowel. So we now have 7 biologics, and I put their brand name as well as their generic name so that you can recognize them. Remicade has been around since 1998. So this was the grandfather of the biologic medications. Remicade, Humira, and Cimzia and Simponi are all TNF-alpha inhibitors. So they block the cytokine called TNF-alpha that signals to other white blood cells that there's an area of inflammation and basically come join the party. So these 4 medications block TNF-alpha. They're very effective. They are all delivered with needles. And sometimes we use them in combination with Imuran or methotrexate because one risk of being on a biologic is your body can become resistant to it. So it can make an antibody to the medication. And the Imuran or the methotrexate helps protect the drug from your body making an antibody. Entyvio is a relatively newer medication. This is also vedolizumab. So Entyvio is a really interesting medication in that it is gut specific. So it is still delivered with a needle every 8 weeks, but it basically traffics to the bowel and it prevents the white blood cells from moving from the vasculature into the bowel. And it doesn't affect anywhere else in the body because it's basically blocking a receptor on the bowel surface. So for patients who are really worried about infectious complications being on a biologic medication, elderly patients that we fear might be at increased risk for complications, this is a great medication, and it's easier to convince patients who have a lot of worries about biologics that if they're on a gut-specific medication, might be a little bit safer. Really elegant studies have been done on Entyvio and immune modulation. So basically, patients on Entyvio are able to mount a completely normal response to the hepatitis B vaccine, but when we give them the cholera vaccine, which is an oral vaccine, they can't mount as strong of a response. So gut specific, remember that. Stelara and Skyrizi are also cytokine blockers, and so they block a different cytokine. Stelara blocks IL-12 and 23, Skyrizi blocks IL-12, 23. These are relatively new. And then kind of fresh on the market, I don't want to bore you or get into too much detail, but these small molecules don't really fit into the biologic or the immune modulator category. You'll recognize them as Xeljanz, Rinvoq, Zeposia, and these are oral. So they're given once or twice daily. Xeljanz and Rinvoq are called JAK inhibitors, so they just block basically part of the inflammatory cascade. Zeposia actually traps the white blood cells in the lymph nodes, so they can't get into the circulation to cause inflammation. The last thing that I talk to patients about is surgery. I usually don't start the first visit with a conversation about surgery unless patients have fulminant disease, but I think it's really important for patients to know that surgery is an option. So for ulcerative colitis, we think of a colectomy as curative. And I'm putting that in air quotes because when you remove someone's colon, you either give them a stoma or an ileostomy, or you give them a J pouch. So a J pouch is basically where the surgeon removes the whole colon, and then they bring the ileum down to the anal canal and sew it so that patients can have bowel movements on a toilet and not into a bag. What they do, and why it's called a J, is because part of the ileum is brought up into sort of this blind limb, and you get this J shape to the pouch, and that gives patients a little bit of an extra reservoir. So the ileum is not designed like a rectum, right? The rectum, I told you, is designed to be stretchy. The ileum is not. It does not have compliance like the rectum does. So when you create a new rectum or a J pouch, you don't have as much compliance. So basically the surgeon gives you a little bit of an extra reservoir, gives you a little bit more time to make it to the bathroom. Patients with a J pouch do not have normal bowel movements, right? So you don't have a colon, which means you can't absorb water like you used to be able to. So bowel movements are always going to be liquid. About 6 to 8 times a day, 1 to 2 times a night is what I tell patients. So again, like air quotes, it's curative in that we got rid of your colon. Do you have normal quality of life or normal bowel movements? No. But for most patients, being able to still have a bowel movement on the toilet is better than having a bag. The other thing that I tell patients before I send them for a colectomy is there's about a 10 to 15% chance we don't have the diagnosis right. We think you have ulcerative colitis. We've done all the tests. We've done all the studies. You've had all your colonoscopies. We remove your colon and the inflammation comes back in your J pouch. Now you have a fistula, you've got bad ulcers, and actually it was Crohn's. 10 to 15% chance. So I approach surgery very carefully with these patients because I don't want them to have the impression that when they get their colon out, their life's going to go back to normal. They might be right back on one of these medications after their colon comes out. And lastly, there's about a 30% chance that patients who have a J pouch will get something called pouchitis. So pouchitis is inflammation of the pouch that's not Crohn's. It's just your ileum is not designed like a colon. So when you introduce colonic bacteria into the ileum, it gets a little irritated. So rotating antibiotics are the mainstay of pouchitis therapy. But again, sometimes patients with severe pouchitis have to go back on immune modulating medication or biologics in order to keep the inflammation under control. Surgery for Crohn's is a little different. So surgery for Crohn's is typically taking care of the complications of Crohn's. So the strictures, the fistula, the abscesses. Inflammation can be removed if we can't get it under control with medications, but you sew those patients back together and the inflammation almost always comes back at the anastomosis. So I try to avoid surgery in Crohn's disease patients because they still have the disease, right? We've not removed the part of the body that is affected. So important that before we send patients to surgery, we have a thorough conversation about what it means, what life is going to look like afterwards, whether or not they're going to have to be on medications after we remove that part of the bowel. So that conversation that I just had with you is basically the conversation I have with all of my new patients. It's an extensive conversation. It's really important that they understand these medications because in order for the medications to work, I have to have patient buy-in, right? So if patients don't believe that a medicine's not going to work, not only are they not going to take it, but the placebo effect is real. It's part of how we treat medication or medicine. So important that we have patient buy-in. Okay, so what can you do if you suspect inflammatory bowel disease? Or I'm sorry, it says BID, but it should say IBD. Twice daily, you should think of it. All right, so the goals for your diagnostic evaluation should be first and foremost to exclude other causes of their symptoms. So is this gallstone disease? Is it peptic ulcer disease? Is it musculoskeletal? And you should also be trying to establish the diagnosis and determine the severity of the disease. Helpful tests, labs. So if they're having diarrhea, please send stool tests. And while you're at it, if you're going to send stool tests for infection, it would actually be really helpful if you sent a fecal calprotectin. So there was one study that showed that in patients who had a normal fecal calprotectin, there was a less than 1% chance that they had inflammatory bowel disease. So this can give all of us a level of reassurance if their infectious studies come back normal and their fecal calprotectin comes back normal. CBC and CMP are a great place to start. So we're looking for anemia, iron deficiency especially, elevated white blood cell count, seeing if their liver tests are abnormal. Nutritional studies I send at least annually in IBD patients. So these are vitamin D, vitamin B12, zinc, folate, and ferritin. You will be shocked at how many patients are vitamin D deficient, not just IBD patients, which are almost always vitamin D deficient, but in your normal patient panel. Refer them to GI for endoscopic evaluation. If you've excluded other causes of the disease or of their symptoms, you have a suspicion that they might have inflammatory bowel disease, please send them to us because we would like to do an endoscopy or a colonoscopy to establish a diagnosis. Whether or not to do imaging, honestly, by the time patients have made it to GI, they've usually had something. They've usually had a CAT scan because they've gone to the emergency room for abdominal pain. Maybe they've had an ultrasound because they're having this colicky right upper quadrant pain. It can be helpful, especially if we see terminal ileal inflammation on a CT scan, right? Or pan-colitis and their infectious studies are negative. So these patients are going to end up with a colonoscopy to establish the diagnosis. And if they have imaging, it can be helpful, maybe get them to a colonoscopy a little bit faster. And then this is really helpful for me as well. If there are other organ systems involved, so the extraintestinal manifestations like we discussed, please send a referral to the appropriate specialist. If they have ocular inflammation, send them to an ophthalmologist, get them in a little bit sooner and a little bit faster. If they have rheumatologic manifestations, that's a plus minus because sometimes just treating the inflammatory bowel disease will get their arthritis under control. They might not need to see a rheumatologist. But if they're on treatment for their IBD and they're still having rheum symptoms, that's a great specialist to utilize. And then please, let's work together. So I would love to be CC'd on all your notes. All my partners would like to hear from you. Please remind patients when you see them in clinic, they need to take their meds on schedule without break. So there's a lot of bad things that can happen if they skip their medications. Not so much the mesalamine agents, they will flare if they come off their mesalamine, but for sure their biologics. So if patients stop their biologics or they skip their biologics, they will become resistant to the medications and they won't work anymore. So please tell them, take your medications on schedule without break if you are seeing them in between my visits. Please make sure that all IBD patients are on a multivitamin and a calcium and a vitamin D. So I told you that they're at really increased risk for osteopenia and osteoporosis. They need to be taking extra calcium and vitamin D. Help me monitor proactively for osteopenia and osteoporosis with a DEXA, at least every 5 years for normal patients. And I know it seems ridiculous to send an 18-year-old for a DEXA scan, but they have osteopenia. They've probably already got it. They've been on steroids, they're underweight, they need a DEXA scan. And if it's abnormal, I have 18-year-olds in my panel who have osteoporosis. And those patients I get in to see the endocrinologist, talk about bisphosphonates. So steroids, malabsorption, chronic inflammation, these all affect bone density. And so that's why the rates of osteopenia and osteoporosis are so high in these patients. And then please don't start steroids unless you notify the gastroenterologist. And I know that sounds, like a little bit too much hand-holding, but it's not because I don't trust you. Of course, I trust you. If a patient is sick, they need steroids to keep them out of the hospital, that's fine. But it means that I need to be doing something different with their medications, right? If they need steroids, their disease is not in remission, they need either stronger meds, different meds, or more meds. And then call me or email me. So that's my email and that's my cell phone. I respond to text. And I'm always happy to chat. And so are my partners who treat inflammatory bowel disease. So the more communication we have, the better patients will do in the long run, hands down. Okay, I just wanted to wrap this up with a case study. So this was a real patient I had in my panel who presented in a very interesting way. So she was 46, abrupt onset of bloody diarrhea, and she showed up like open access basically for a colonoscopy. She worked as a CNA at an assisted living facility, and she'd had recent exposure to clindamycin for a dental abscess. So everyone in the room should be thinking C. diff, right? So she's a CNA at an assisted living facility. She's just been on Clinda. And that's what I was thinking. I was like, oh man, we're gonna have to terminal clean this room because this lady just showed up with C. diff. But no one had sent stool studies, and she had recently quit smoking. So a couple little hints there. This is what her colon looked like. So this would be described as moderately severe pancolitis. So the top picture is her cecum. The bottom picture is somewhere in her left colon. And what I saw, the formatting must have moved the pictures around a little bit. So her colonoscopy, moderately severe pancolitis, her ileum was normal. I sent her stool for culture and C. diff, and I empirically started her on Flagyl. This was back in the day when Flagyl was the first line therapy for C. diff, because I was so suspicious that she had C. diff. I saw her in clinic 3 days later. Her stool studies came back negative, not C. diff. And her pathology came back notable for chronic inflammation. So the pathologist said that this is chronic colitis, which is different than acute colitis. So acute colitis is not Crohn's disease or ulcerative colitis, it's something else. It's an infection, it's a reaction to a medication. So you have to see chronic changes in order to diagnose inflammatory bowel disease. And the pathologist thought that in the right clinical situation, this was more suspicious for ulcerative colitis than for Crohn's disease. He said there were no granulomata, so that's the board question. What do you see on biopsy results? You see granuloma in Crohn's disease. We see that really rarely. It's about 4% of biopsies for Crohn's come back with granuloma. So even though that might be the answer on the boards, just because you don't see granuloma does not mean it's not Crohn's disease. So I stopped her antibiotics. I put her on prednisone, which I just told you never to do, but she was really sick, and I wanted to get her feeling better quickly. So it's a bridge therapy to her maintenance medication of Lialda 4.8 grams a day. One could argue this is moderate inflammation. Why didn't you go to a stronger medication? In ulcerative colitis, I like to give them a chance to fail mesalamine therapy before I move on to something stronger, because there's a majority of patients with moderate inflammation that will actually respond to Lialda and might not need to go to stronger therapy. And then 2 days later, this lovely 46-year-old CNA was found unresponsive at home with decorticate posturing, and she was rushed to the hospital. The CT scan confirmed basilar artery thrombosis. She was taken emergently to the OR for thrombectomy. They tested her for hypercoagulable traits. That was negative. And this lady, literally, she was in the ICU on a vent, and they were trying to wean her sedation and get her off the vent, and she had a whiteboard, and she wrote, "Call Dr. Evans." And the ICU was like, what? So they called me and they said, why does this lady think that we need to talk to you? And I was like, oh, well, I mean, I just started her on some medications, but that is not what caused this stroke. She's hypercoagulable from her ulcerative colitis. So we need to get the inflammation under control, and you need to start her on warfarin. And I don't care if she's having rectal bleeding. She needs to be anticoagulated. So she started warfarin as an inpatient. She made a full neurologic recovery, which was amazing. She had some like word finding difficulties when I saw her back in clinic, but successful thrombectomy. And this is what her colonoscopy looked like 3 months later on Lialda. So endoscopic and histologic remission of disease. That's it. I'm happy to take questions.
Second quick question.
Yeah.
The slides that you showed that were of her colon that was really inflamed, can you just tell me what that was? What are?
Yeah, so basically the white stuff is pus. So she's got inflammation, and her colon is kind of shedding layers. And so red is erythema, white is pus. And what I typically tell people when I show them these pictures in the clinic is your colon should be pink. You should be able to see the blood vessels. It should be shiny. So this is light reflecting off of the colon because it's nice and healthy mucosa. Yes.
So while they're waiting to get in with a GI specialist, when they're having a flare-up, do you have a preference on the steroid dose that you recommend for most patients? patients is going to be the one starting or something?
Yeah, it depends on the severity of symptoms. So for patients who are really sick, who are, having 20 bowel movements a day and they're bloody and they can't go to work, 40 milligrams of prednisone is a good dose.
You do for like a 5-day, 10-day?
So first call me because I can get them into clinic tomorrow, right? So if you have a patient who's flaring and they're sick and they're at risk of going to the emergency room or the hospital, call the gastroenterologist, because if you send the referral, they're going to get a clinic appointment in 3 months. So call the gastroenterologist and say, I have this patient who's really sick. What do you recommend I do? And we will give you a recommendation for meds or stool studies, steroids, and then we'll get them into clinic fast, okay? But yeah, prednisone 40 is a good place to start. Please don't leave them on prednisone 40 for months because that's the worst possible treatment. And then secondly, budesonide or Ulcerative is gut specific, and so it does not have as many of the systemic side effects as prednisone does. So for patients who sort of have this mild to moderate flare, that might be a nice tool in your toolbox. So Ulcerative is the brand name. It's 9 milligrams. Budesonide is the generic. They come in 3 milligram tabs. You can give 3 of them to add up to 9 milligrams. And I like to use budesonide over prednisone if I can. It's expensive and it's not always covered by insurance. And so if you can't get them Ulcerative and their symptoms are more severe, absolutely go for prednisone. Yes?
Is there a particular diet you recommend for patients with active IBD?
Great question. And patients want to know that all the time as well. So for patients who are in a flare, I just tell them to eat what feels good. There is nothing that's been shown to decrease inflammation in terms of diet. So I tell them eat bland, stay away from spicy, greasy foods, which cause diarrhea in normal people. Probably try to stay away from dairy, which can also cause more GI symptoms. So eat bland foods. The BRAT diet is a good place to start. That's for patients who are having a flare. Yeah.
So for folks with Crohn's who can't afford biologics, what is the most cost effective, who might be a candidate for biologics, but their insurance, their copay is like $1,500 a month, et cetera. What's the best? Do you combine methotrexate and sulfasalazine, et cetera?
Great question. So first, let me say that if you're having trouble getting a patient on a biologic for cost reasons, please let me know, because there are excellent patient assistance programs with the drug companies. So patients can qualify who have little income, no income, uninsured, underinsured. So most patients can get Remicade or not Remicade, but Humira for $5 a month. So if we can't get them on a biologic for whatever reason, their copay is too high, they don't qualify for a patient assistance program, patients who are on Medicare, unfortunately, fall into this donut hole. So, Medicare will cover $5,000 and then they fall into the donut hole until they get to $50,000, and everything in between they're responsible for. We do have good patient assistance programs for that. It's better if they're on an infused medication because it falls then under their hospital coverage instead of their pharmaceutical coverage. So those are things that I keep in mind. But yeah, I sometimes have to work with what we've got. So methotrexate and sulfasalazine are dirt cheap. So is azathioprine. And so while I don't like patients to be on monotherapy with methotrexate or azathioprine, sometimes we have to do that. The reason is because they are inferior to the biologics in terms of efficacy, and they have a lot more side effects. So methotrexate can cause flu-like symptoms. It can cause hepatotoxicity. Azathioprine can cause a serum sickness reaction. It can cause pancreatitis. So these are medications with real side effects. I use them when I have to. I don't love using them as monotherapy. Did that answer your question?
Would you continue sulfasalazine?
Oh, in a patient that I was putting on methotrexate or azathioprine, yes, if I needed it. If there were no other options, yes. I do that with the rheumatologist all the time.
Thanks so much, Dr. Evan. My one quick question was about how do you speak to patients about use of alcohol in a setting of IBD?
Yeah, okay. So I talk to my IBD patients the same way I talk to all my patients about alcohol, which is that everything in moderation. There's no reason that they can't drink alcohol unless they're on methotrexate, then I would really want to limit their alcohol. But I don't tell them that they have to stay away from it. I don't tell them that it increases their risk. I don't tell them that it increases their inflammation because I don't think that we know that.
What about smoking?
Good question. All right, so when I was at University of Chicago, there was an old school gastroenterologist who would tell his patients to smoke to treat their colitis. Yeah. And I mean, is it a great idea? No, I don't tell my patients that because I think the risk of continuing smoking, even 1 or 2 cigarettes a day, is higher than the risk of colon cancer from untreated colitis or from one of the medications causing a bad outcome. So I tell patients to quit. But yeah, I mean, it is interesting. There is a school of thought that says maybe if you won't need any medications, your colitis might stay in remission if you just smoke 1 or 2 cigarettes a day. Not the same for Crohn's. Crohn's patients absolutely have to quit smoking because it increases their risk for bad complications. And if they ever need a surgery, a surgeon's just gonna, be super upset that they're still smoking. So Crohn's patients need to quit.
Is it the tobacco or the nicotine?
We don't know. Nobody knows.
Just wondering vaping, right?
Yeah. So, I mean, if you chew, it doesn't have the same effect. So it's not just nicotine. It has something to do with the milieu of chemicals in the cigarette, and we don't know. Yeah. Nitric oxide has been implicated, but nobody knows.
I have a question. This is probably going down a rabbit hole, but
Oh,
I was
yeah.
wondering
Okay.
about the pathophysiology of the IBD and then these extra
Intestinal manifestation.
manifestations.
Yeah.
What is the link? What's the link?
Well, it's basically your immune system has been activated in an inappropriate way. And so when you have an inappropriately activated immune system, that same immune system that's attacking the bowel can go to other places in the body and cause inflammation. So it's just active inflammation of your white blood cells that are causing destruction in the body. Yeah.
Do you send all patients that are recently diagnosed with IBD for DEXA?
I do. Yeah. And like I said, the radiologist is going to be like, what is this 18-year-old doing? But it's really important.
Yeah, so even if they haven't been on steroids for a long time, you send them all.
Can you repeat that for the audience?
Yes. So the question was, even if they haven't been on steroids or they have just been diagnosed, do I send them for a DEXA? And I do. Even if it's just to get a baseline. If it's normal, great. But if it's not, then we become more aggressive about treating osteopenia.
And IBD is the coordinated diagnosis that insurance will pay for?
They will. Yep. Crohn's or colitis. Yeah, they will. Yes.
Can you comment on the vaccination recommendations for patients on the vaccine?
Yeah. Okay, good. So they should be vaccinated. So they should get all of their vaccines. The ones that they cannot get once they're on a biologic are the live vaccines. Okay. So polio, measles, mumps, rubella, there's a few more. But they can't get live vaccines once they're on a biologic, so they should be up to date on all of their vaccines before they start a biologic. Otherwise, they should get all vaccines on schedule. The COVID vaccine is a common question that I get. Should I get the COVID vaccine? Yes. Do I need extra COVID vaccine? No. Can I still be on medications to treat my Crohn's disease if I get COVID? Yes. So COVID is, we're learning more about COVID as we go on, but there's a great ongoing study about patients with inflammatory bowel disease who are on meds and get COVID. And what we have found is that patients on medications, even on biologics who have inflammatory bowel disease, are not at increased risk for getting COVID. And they don't have any worse outcomes when they're on these medications. In fact, there's a theory that patients who are on biologics might have better outcomes. People are looking at using medications like infliximab for treatment of bad COVID because the serious complications of COVID actually come from your immune response, right? So patients do not do worse. They're not at increased risk. So yeah, I mean, everyone should get vaccinated for COVID. All the IBD patients should be vaccinated just like everyone else.
Okay.
Thank you, Dr.
Okay, thanks. That was great.
In an hour.